Welcome to today's cardio-oncology session. I am Teresa Lopez from La Paz Hospital in Madrid, Spain, and I have the pleasure of being joined by Dr. Suter from Bern, Chair of the ESC Council of Cardio-Oncology. The aim of this session is to give you a better understanding of cardiovascular toxicity of cancer therapies, and we are going to focus on three main clinical aspects. First, how to stratify cardiovascular toxicity risk in clinical practice, then how to improve the diagnosis of the different cardiovascular toxicities of anti-cancer therapies, and finally, how to monitor these cancer treatments and how to improve early diagnosis of cardiovascular toxicity. This session is interactive, so we strongly encourage you to actively participate by sending your question and comments using the chat you have on the website. And I will now hand over to our first speaker. It is my great pleasure to introduce Dr. Alexander Lyon, Director of the Cardio-Oncology Program at Royal Brompton Hospital and Imperial College London. Please, Alex.
Thank you, Teresa, and good morning and welcome to everybody to this session. And I'm going to talk about how to estimate the risk of cardiotoxicity in clinical practice. Here are my conflicts. So we've known for many years that different types of cancer treatment can cause cardiovascular disease, such as anthracycline chemotherapy, high doses of radiation therapy to the heart, fluoropyrimidines, now used a lot in gastrointestinal and ovarian malignancy, and prostate cancer drugs known as androgen deprivation therapies. We've also learnt that if patients develop advanced heart failure after their chemotherapy, it's an aggressive, nasty heart failure to have. This is data from the heart failure service at Brigham Hospital in Boston, which showed that in patients with advanced heart failure, those who had it due to chemotherapy in the red dotted line had a worse overall survival. This on the left is the survival free of death, and on the right, survival free of death, transplantation, or left ventricular assist device, compared to the blue group, which is all other causes of heart failure. So letting chemotherapy cause heart failure is a bad thing to happen. But we know when these patients are going to have their treatment, and therefore this is a real opportunity for prevention. And now we see this explosion of new targeted cancer therapies, which are effective in treating specific cancers, but cause cardiovascular disease. And here's a list where we have patients in our service where a heart problem has been caused by one of these drugs. So how can we personalize our approach to risk? So last year, the Heart Failure Association, together with the International Cardio-Oncology Society, published this document, and I had the privilege of chairing a wide group of experts from around the world, oncologists, hematologists, and cardiologists, to identify what were the risk factors that predicted patients getting problems on these different cancer treatments. And what we came up with is different groups of risk factors. The highest risk here in red is pre-existing heart disease already puts a patient in a high-risk group. Then there are the standard cardiovascular risk factors: hypertension, diabetes, elevated cholesterol. Lifestyle risk factors: obesity, smoking. And then if we measure cardiac biomarkers at baseline and they're abnormal, that also increases and predicts a higher risk group. And finally, many cancer patients are coming for a second or subsequent treatment, having had previous cardiotoxic chemotherapy for a prior cancer or for their cancer that's now come back or recurred. And therefore, their lifetime exposure to cardiovascular or cardiotoxic drugs is important. And what we created are these one-page proformas, and they're available in the data supplement of the paper. So you can download them and either electronically or print them out and use them to risk stratify patients, and encourage your oncology and hematology colleagues to use these, because that's where all the patients are being assessed before treatment. And what you have here is in the first column, the specific risk factor, Then you can add, is it present or absent? Yes, no. Then there's a score to that risk factor, high or very high when we think of pre-existing heart disease, and then medium risk factors, and these have a point system of 1 or 2 depending on the weighting of the risk. And then for the paper, we have the level of evidence and references that support this. And ultimately, you have patients then in the low risk category who have no risk factors or one single medium with 1 point. Medium risk factors at medium risk where 2 to 4 points have been accumulated, and high risk group who have 5 or more medium points or a single high risk factor or more. And then the very high risk groups where, for example, pre-existing heart failure before needing anthracycline. And here's a similar pro forma for the patients receiving HER2 targeted therapies such as trastuzumab with a similar structure and then the risk score. We at the Royal Brompton Hospital partnered with our cancer colleagues at the Royal Marsden Hospital and retrospectively studied the application of the trastuzumab risk score to a large population of breast cancer patients. And this was published earlier this year in April. And from the era of 2011 to 2018, we identified 931 women receiving trastuzumab at the cancer center and assessed their cardiovascular risk at baseline pre-treatment. And in this real-world cohort, 43% of the women were low risk, just under 49% were medium risk, and over 8% were high or very high. Now, the overall rate of cardiovascular toxicity in this cohort was 16.6%, so a reasonably high rate of toxicity. And the risk baseline risk assessment could identify the patients at risk. So the high and very high group had an overall risk of event rate of cardiovascular toxicity of over 30%, compared to about 16% in the medium risk and 13% in the low risk. The low risk includes those with 0 points and 1 point. And interestingly, if we break that down by the absolute points, you see that if there are no risk factors, the risk is low, 7.5%, compared to the very high risk of 30%. But across the medium risk group, there wasn't a gradation, so we need some improvement in this. I want to emphasize that while we all focus on heart failure and preventing heart failure, there are other risks. And for prostate cancer patients, vascular risk is important. And therefore, we discuss the importance of looking at their 10-year cardiovascular risk. And there are a range of risk calculators that have been developed in the general population, which we recommend are applied to prostate cancer patients before and during their treatment. To give you a flavor of this, here is one case of a patient I've looked after in London, 61-year-old gentleman with locally invasive prostate cancer. He had a background of hypertension, hypercholesterolemia, and a BMI of 28. So in the UK, we can use the JBS3 cardiovascular risk calculator. And if you put in date of birth, gender, his height and weight, social background, smoking status, cholesterol profile, blood pressure, and other risk factors, we can then calculate a 10-year risk, and that was 13% at baseline. He then got treated with goserelin or Zoladex, the GnRH agonist for his prostate cancer, and at 6 months, he'd gained 5 kilograms in weight, and this is mainly abdominal adiposity. His cholesterol had gone up, and he now has new diabetes, which occurs in 25% of patients on this drug. And so if you now put in this new data, look at what's happened to his cardiovascular risk, well, it's gone up from 13% to 24% just with 6 months of treatment. So we need to think of how we can then treat him to minimize this risk. And of course, one option is to use this ABCDE algorithm about optimizing the cardiovascular risk and a focus on vascular risk in these prostate cancer patients, at the beginning before they start treatment, and then monitor and repeat the assessment during a treatment. So finally, where do we see this field going in the future? Well, there's lots of information being gathered about these patients when they come up for their serial assessments. And I think using artificial intelligence and modern science to be able to really improve the precision, I think our baseline performers are the start of this journey, and that I'd encourage you with your oncologists and hematologists to use them, implement them, identify low-risk patients who can just continue with treatment with a lower level of monitoring, and the high-risk patients who maybe should come to you as cardiologists and cardio-oncology services to optimize and minimize their risk pre-treatment, and then have a tailored monitoring approach. And you'll hear more from the next two speakers about how we can monitor patients during their treatment. So I'm going to hand back to Dr. Suter, and thank you for your attention.
Well, thank you very much, Dr. Lyon, for an excellent presentation. It's now my great pleasure to introduce the next speaker, who is Professor Zamorano. He is the head of cardiology at the Remo y Cajal Hospital in Madrid, and he is going to talk about how to diagnose cardiotoxicity of anti-cancer treatment. Pepe, please.
Thank you, Thomas, for this kind introduction. I'm very happy to be with all of you, and hope everybody is safe. Well, I think that the first thing that we need to realize is what are the possible complications that we can expect. And this was nicely reported in the previous position paper from the ESC. So when we're talking about the complications, it's not only heart failure that is the most common or the most popular also, but we need to think that there may be complications in the valves, in the arteries, in the conduction system, so as in some risk factors like hypertension, VTE, etc. And also the complications could be acute, subacute, or late complications. So it's not that we only check the status of the patient when starting the treatment or when entering in the cardio-oncology clinic. And this was very nicely addressed in the paper from Daniela Cardinale in 2015. And as you can see here, the cardiotoxicity is really a continuum. So we can start thinking in a myocardial cell injury that may lead to myocardial deformation. For some months, even years, the patient could be asymptomatic. And at the end of the day, these patients can enter in the last step of the stair, that is the overt cardiotoxicity. So in fact, the main issue that we are thinking, or we should be aware of, is that it's a real continuum. And this is why we need to follow these patients from the beginning till the end. There are some factors that can be related also to the cardiac toxicity, like the dose of the agent that we are using, the age of the patient, and even the gender of the patient. So obviously, as you have heard previously in the presentation, each patient is a different scenario, and we should be clear and concrete on each patient, what is the risk and what to do. I really love this slide that was given from Teresa to me, and it's a nice chart showing how could be the path of our patient. This is extracted from a submitted paper, and the treatment with potential cardiotoxic cancer therapeutics agents, it could be present signs and symptoms of heart failure, that we should go to a diagnostic evaluation and see clearly the clinical status of the patient, and after that, classifying a severe, moderate, or mild clinically cardiac toxicity. Well, I think that if the patient is asymptomatic without any signs or symptoms, never forget that cardiac imaging or biomarkers are really crucial here. We should assess not only, as we will see later, the ejection fraction, and according to the numbers of the ejection fraction and the GLS, we could classify the patient in mild, moderate, or severe asymptomatic, but with already affected heart. Well, arrhythmias is also quite relevant in our patients. Never forget that every single type of arrhythmia could be present in the patient, and we should be aware of. QT prolongation is crucial. It could be life-threatening and is quite relevant to establish the severity of the QT prolongation, but also check the ECG not only at the start of the therapy or when the patient enters in the cardio-oncology clinic, but also is during the follow-up. Could be 1, 3, 6, or 12 months, but we should have here an open mind and establish the follow-up of the ECGs again according to the patient. Confirm what is the severity of the length of the QTC, rule out possible electrolyte imbalance, check the drug interactions. So never forget these patients receive many different drugs, and obviously we should stop other QT prolonging drugs that this patient may be receiving. Well, what can we do for early detection? Now, we know a lot, but to know is not to do. So what we should do? First, establish the general risk factor of the individual patient, the pre-existing conditions. Analyze and carefully take note of all the concomitant cancer therapy drugs that the patient are receiving. Obviously, which drug, which dose, or which drugs, what doses of the different drugs. And also recognize potential apoptosis, measurement of biomarkers, troponins, another factors or another like BMP that implies elevation of LV filling pressures, and obviously recognize LV remodeling, and echo here is the cornerstone of our diagnosis. Early diagnosis is critical. And as you can see here in this graph, the evidence of a normal LV ejection fraction does not exclude the possibility of a later cardiac deterioration. And this is very important. Why? Because GLS is entering in the scenario quite importantly. I think that in this paper from Juan Carlos Plana, you can see that a relative reduction of the strain that is more than 15% from baseline is likely to be really abnormal. So if we start from the ejection fraction, in this paper less than 53 implies obviously that the patient has a problem already, but even if it is the ejection fraction is normal, we need to rule out what happens with the LV mechanics. And here GLS is quite important. Well, what do the position paper recommends? Well, ejection fraction 10%, GLS 15%. You can establish that. I think it's less used or much less used than echo the MUGA, the nuclear cardiac imaging, and also never forget that biomarkers could be useful in some patients or scenarios. Well, finally, I want to close with reviewing this nice paper from Chiro Santoro, and this group established a strain-oriented strategy for guiding the cardioprotection in our patients, in this case with breast cancer. The definitions were overt CTR-CD, decrease in ejection fraction more than 10%, to the value below 50%. Subclinical is GLS reduction more than 15%. And the definition of full recovery was ejection fraction recovered to baseline, and partial recovery, ejection fraction recover above 50%, but below baseline values. So what happens here? If the patient has no change in LV function, continue with the anti-cancer therapy. If the patient with overt CTR-CD, interrupt anti-cancer treatment, cardioprotection with ACE and beta blockers, and see if the patient has full or partial recovery. If there is no recovery, then interrupt the anti-cancer treatment. If the patient shows a subclinical, well, here start cardioprotection and continue with anti-cancer therapy. And as you can see here in this final slide, in fact, this strategy shows that it could be clearly beneficial for our patients. So what is my summary and my conclusion, dear friends? The goal is never stop life-saving chemotherapy. This is clear. So the goal is recognizing patients at risk, consider other potential strategies without cardiac toxicity or with less cardiac toxicity, and use a sensitive method for early detection. And here, early detection in terms of imaging implies wide use of GLS-oriented approach in detecting this complication, and obviously implies a prompt and rapid instauration of treatment. Thank you very much.
Thank you, Dr. Zamorano, for this outstanding presentation. And now it's my pleasure to introduce Dr. Popescu. Dr. Popescu is Professor of Cardiology at University of Medicine and Pharmacy, Carol Davila, and head of the Cardiology Department at the Institute of Cardiovascular Diseases, Professor Ilescu, and past president of the European Association of Cardiovascular Imaging. Please, Dr. Popescu.
Dear colleagues, I'm glad to be part of this interesting session. There's clear evidence that cardiac monitoring in certain anti-cancer settings helps limit the cardiac impact of a patient's cancer therapy. Surveillance strategies should take into account the baseline cardiovascular risk factors and comorbidities, the type of anti-cancer treatment and their side effects in order to make an individualized choice. Monitoring could be done either using biomarkers or cardiac imaging, or preferably a combination of them. The same modality should be used during follow-up, and preference should be given to tests with the best reproducibility, to modalities that provide relevant clinical information of high quality in a radiation-free environment. In a recent large meta-analysis, it was shown that anti-cancer therapy is very often accompanied by an increase in troponin, and patients with elevated troponins are at higher risk for LV dysfunction, and therefore troponin may complement the cardio-oncology workup. The high negative predictive value of troponins for the detection of LV dysfunction, 93%, implies a further benefit of troponins as a screening tool for LV dysfunction. However, data on the predictive value of troponins for cardiotoxicity-related heart failure or mortality are not yet available. From the same meta-analysis, elevated BNP levels in patients with LV dysfunction were only present in the anthracycline-treated subgroup, and also the presence of elevated BNP was not consistently associated with decreased ejection fraction. So the conclusion of this meta-analysis was there is not sufficient evidence for natriuretic peptides in predicting an increased likelihood for cancer therapy-related LV dysfunction. The general recommendations for biomarkers measurements included in the recent position statement issued by the ESC last year include that baseline measurements of natriuretic peptides and troponins should be considered being particularly important when other cardiovascular diseases are present. The timing of biomarker measurements should be tailored to each biomarker therapy combination, and this should guide decisions to increase monitoring frequency, initiate cardioprotective therapy, or trigger more intensive investigations. Of note, as already been mentioned before, in isolation, an increase in cardiac biomarker will never or rarely justify a stop of evidence-based chemotherapy. The same document makes recommendations for specific cancer treatments. For example, for anthracyclines, cardiac troponins appear to be better able to identify early myocardial injury, whereas natriuretic peptides appear to better detect late onset cardiotoxicity and heart failure. The timing and intensity of biomarker surveillance is mostly driven by the patient's baseline cardiovascular risk assessment. It's known that trastuzumab may amplify pre-existing cardiotoxicity from anthracyclines, and this should be considered together with the baseline cardiovascular risk when deciding about the timing and intensity of surveillance in this setting. The general principles of cardiotoxicity imaging were summarized in another recent ESC document published last year. And the main messages are that current definitions of cardiotoxicity are based on a reduction in ejection fraction. However, we know that a normal EF does not exclude significant myocardial dysfunction. Serial measurements of ejection fraction have potential significant limitations. Cardiac magnetic resonance should be considered in some selected cases. Global longitudinal strain, as you have heard, emerges as a useful tool to assess subclinical LV dysfunction, and importantly, imaging data should be combined with clinical and biomarker data. For measuring ejection fraction with echocardiography, 3D echo is the preferred method whenever endocardial definition is clear, and that is because, as you can see here, non-contrast 3D echo has the lowest variability and the smallest minimal detectable change when compared to the other methods. However, even when measured properly, ejection fraction has many limitations: technical issues, test-retest variability, failure to detect subclinical changes in LV function, and load dependence, which may be particularly relevant in cardio-oncology related to treatments and side effects. Also, serial EF measurements should ideally be performed by the same observer on the same equipment in order to reduce variability. Cardiac magnetic resonance remains the gold standard for LV volumes and ejection fraction, having a high reproducibility and improved accuracy. CMR is also important for cancer patients receiving immune checkpoint inhibitors with new symptoms, arrhythmias, or troponin elevation whenever ICI-mediated myocarditis is suspected. And here in the images, you can see different distributions of late gadolinium enhancement in different patients with ICI-mediated myocarditis. Global longitudinal strain measured by speckle tracking echo is the most studied and robust strain parameter, being the optimal one to detect subclinical LV dysfunction. A baseline value should ideally be obtained before treatment. A relative percentage reduction of more than 15% is very likely abnormal. Same vendor-specific echo machine should be used for follow-up. These are important practical considerations. And here you have an example from a patient we have enrolled in the SUCUR study with a relative reduction of 17% in GLS at 4 months follow-up, while EF measured at the same time moments remained unchanged in the normal range. The SUCUR study was a randomized study to compare GLS versus an EF guided approach to initiation of cardioprotective therapy. Patients were randomized to either a GLS guided arm, with cardiotoxicity being defined as at least 12% relative reduction in strain at any time of follow-up, versus an EF guided arm with a toxicity defined as a symptomatic drop of more than 5% or an asymptomatic drop of more than 10%. And whenever these cutoff values were reached, cardioprotective therapy was initiated. And GLS detected cardiac dysfunction occurred earlier and more frequently than EF detected cardiac dysfunction. So a GLS-based approach to cardiac surveillance, followed by initiation of proper cardioprotective therapy, reduces the degree of reduction in ejection fraction and the incidence of cardiac dysfunction at 1 year follow-up. These are promising results for a GLS-based surveillance. I would end my presentation with these two diagrams proposed in the recent ESC document, highlighting the importance of combining imaging with biomarkers monitoring and again, the importance of baseline risk assessment in individualizing the surveillance strategy. Here is the proposed scheme for the anthracycline surveillance protocol. And here is the proposal for trastuzumab surveillance protocol with the same principles applying. The higher the baseline risk, the closer the follow-up. So to conclude, cardiovascular safety should be monitored in patients undergoing anti-cancer therapy. Echocardiography plays a central role in monitoring these patients and guiding patient care. GLS is more sensitive than ejection fraction in detecting early dysfunction and could be a better option to guide timing of cardioprotective treatment. And current algorithms combine imaging with biomarker assessment as being synergistic and complementary approaches. Thank you.
Thank you, Dr. Popescu, for your very insightful presentation. And now we are going to open the debate. Please feel free to send your question if you haven't done yet. And I will now hand over to Dr. Suter to lead the discussion.
So for the sake of the discussion, I would like to introduce two patients. The first patient would be a 75-year-old woman with a long-standing arterial hypertension who has left-sided HER2-positive breast cancer and is scheduled to be treated with anthracyclines and cyclophosphamide, then followed by Taxol and then Herceptin, and also should be radiated to the left chest. The second patient is a 72-year-old patient with multiple myeloma who has a history of coronary artery disease, pre-existing AC bypass operation with an LV ejection fraction that is 50% and should be treated with CyBER-D, so cyclophosphamide, Velcade, bortezomib, that is, and dexamethasone. So let me start with Alex. So if you see such a woman, the breast cancer woman, and you would do your assessment, what would be your conclusion based on your assessment for this patient? Would you change the schedule, how you monitor this patient?
Thank you, Tom. That's a very common real world problem case. So when I look at that lady, I would calculate her risk using the baseline risk score, and with her age and hypertension, she's definitely racking up points into that medium risk. Whether it transitions into the high risk will depend on maybe her baseline biomarkers. Does she have signs of hypertensive heart disease on her baseline echo, such as left ventricular hypertrophy? What's her ejection fraction at baseline pre-treatment, and her symptoms? And I also want to know, is her blood pressure well controlled, and which drugs is she taking for her blood pressure? Because we know that ACE inhibitors or angiotensin receptor blockers and beta blockers may offer cardioprotection, whereas if she's on calcium channel antagonists or diuretics, they're going to be less effective at offering protection. So we would also look at whether to optimize her blood pressure medication using cardioprotective drugs. And then I think she definitely requires closer monitoring compared to a low-risk patient, and probably in the medium sort of risk category from the data you provided, unless her baseline echo or biomarkers shift her into a high-risk group.
Thank you, Alex. I completely agree with you. So let's take then the second patient, Dr. Zamorano. If you have this patient in your clinic prior to treatment, everything is fine. We said the LV ejection fraction is 55%. And this patient now undergoes treatment with CyBER-D and develops dyspnea and will be referred to you again. What will be your preferred method of detection for this patient?
Yeah, thank you, Tom. I think this is a very interesting patient because it's a typical case where we should not only focus in the LV ejection fraction. So if I remember properly, this patient had a severe coronary artery disease with bypass. So I think that what is crucial is not only assess LV mechanics, what is happening to the LV, but also rule out ischemia in this patient. So even subclinical ischemia may interfere with LV ejection fraction and LV function. So two things here to consider. Obviously, what happens in terms of LV mechanics and potential influence of the different drugs. And secondly, rule out ischemia because this patient is with severe atherosclerosis and bypass surgery.
Excellent. I completely agree, Pepe. So, Dr. Popescu, let's go back to our first woman, and let's assume that she is undergoing cancer treatment. She is undergoing her chemotherapy with anthracycline and cyclophosphamide, and now she represents to you with a new onset atrial fibrillation. Would you still trust your assessment by echo, or would you switch now to MRI imaging? And what would be the advantage, if so?
Thank you very much. Sure, I think that's an interesting case and a real-world case. So I think, of course, I would first do the echo and see whether there are changes compared to the baseline value, baseline assessment, which we should perform, and it has been mentioned. And then, of course, perhaps the MRI would help us in case we are not sure about the ejection fraction, or we would like to see further added information. In this case, I think the added value would not be that high. We should go with the echocardiography and with measuring also GLS in case ejection fraction is preserved, because we know this can identify subclinical dysfunction even in this scenario. And of course, we would treat properly the atrial fibrillation. In such a case, it is important to also assess properly left atrial size, which for sure CMR is better. But in case we have a good echo window, I think we can do this the same with the echocardiography.
Thank you, Wolfgang. So back to Alexander. Let's assume this patient with multiple myeloma is presented to you, and you're concerned about him because he describes that he would have difficulties to climb one flight of stairs. Would you be inclined to discuss with the oncologist the potential treatment? Would you discourage the oncologist from the planned CyberD treatment?
So this is symptom limited before starting treatment. Well, then we need to work out why. Is it cardiac limitation, respiratory? Multiple myeloma patients have a higher risk of venous thromboembolism, and the IMiD drugs such as lenalidomide and pomalidomide may increase that risk. So if it's a symptomatic patient pre-treatment, then it's about optimizing what the diagnosing the cause. Cardiac, respiratory, is it blood pressure, ischemia, heart failure? And then if they're presenting on treatment, again, there's a wide range of differentials. Velcade's relatively low risk, but certainly patients on carfilzomib, the second line proteasome inhibitor, have a much higher risk of new heart failure. And then all of these myeloma patients have a high thrombotic risk for both arterial and venous thrombosis. So one has to have a wide thought process for a diagnosis. And again, imaging, cardiac imaging and biomarkers are key.
Excellent, Alex. Well, Dr. Zamorano, let's talk about this same patient. How frequently would you monitor him? Let's assume that his dyspnea is not worsening.
Yeah. And also assume that the patient has not chest pain, because this also will impact. So I think that the patient is in high risk, and we will monitor at least one every 2-3 months. If the patient is going well, if the patient immediately develops heart failure or ischemia, then the patient, or any complication, then we will reassess this patient.
Correct.
Okay, I think that we are now approaching the end of this session. I would like to thank Dr. Suter and all the speakers for this great discussion. And first, I would like to invite you all to join us at the ESC Council of Cardio-Oncology, and then to summarize 2 key messages for your daily practice. First, cardio-oncology strategies are critical to minimize the impact of cancer therapies in patient prognosis. And of course, the goal is to recognize the patient at risk and promote early diagnosis and management of the different cardiovascular toxicities to minimize cancer treatment interruption and also to minimize the risk of cardiovascular problems. Thank you for attending this session.